Starting off with C1, you can palpate the transverse process of C1 between the angle of the mandible and the mastoid process. This is a prominent bony lump. The transverse process of C2 is parallel to the angle of the mandible. Coming slightly medial to the sternocleidomastoid muscle, you can also then, a few centimetres below this, palpate the transverse process and lateral mass of C3. And again, a few centimetres below this, you can palpate C4 vertebral level. Once you reach C5 level, it's easier to palpate the transverse processes lateral to the sternocleidomastoid muscle. Because C6 transverse process has the carotid tubercle and the anterolateral aspect, it makes it easy to identify this level and can confirm whether you're on the correct level. And then you can palpate C7. In some individuals, you can palpate all the way down to T2 or 3 anteriorly, depending on their body alignment. As with the cervical spine, prior to doing any specific joint palpation, we need to assess the skin and the soft tissue of the thoracic area generally first. You can assess skin temperature and the presence of excess sweating using the back of your hand to stroke down the thoracic area. Increased skin temperature or excess sweating can indicate an autonomic dysfunction. In the presence of inflammatory change, you can also have increased skin temperature as well. You can specifically assess the soft tissue, palpating the various soft tissues around the thoracic spine. Prior to doing this, you can ask the patient to tell you whether any symptoms are reproduced on palpation of the soft tissues. When you're palpating the thoracic spine, it is best to stand facing towards the patient's thorax. And to facilitate palpation of the interscapular muscles, I have the patient prone lying with the arms hanging over the edge of the bed. During your soft tissue palpation, you may feel areas of tightness or muscle spasm. In conjunction with other findings, this will help to form your clinical impression. In this position, you can also assess the bony structure of the back. You can assess for the presence of any bony abnormalities or any deviation from the normal alignment. You can start off at C1 level and palpate the spinous processes all the way down the thoracic spine. Or you can start where you think C6 and C7 spinous processes lie. Ask the patient to extend their head and back down again. And if you're at the correct level, the C6 spinous process should disappear underneath your fingers and the C7 stay relatively still. So that's C6 and 7, so this must be T1. So you can work your way down the spine, palpating the spinous processes. You can use a pincer grip to see whether there's any deviation from the normal alignment of the spine, or you can palpate just directly posteriorly. Remember when you're palpating the thoracic spine that the spinous processes overhang. So the spinous process in the center or the mid level of the thoracic spine is level with the transverse process of the vertebra below. To palpate the transverse process, you go 2 to 3 centimeters laterally from the spinous process of the level above. If you want to confirm that you are on the transverse process of a particular spinal level, you can palpate the spinous process of that level. You should be able to appreciate some movement occurring at the transverse process at the same level. The transverse processes overlie the costotransverse joint. The costovertebral joint lies deep and was not possible to palpate from this position. From the transverse process, at each level, you have the rib. The rib passes laterally, and about 7 centimetres from the midline, the rib changes its angle, and you'll notice a bony prominence known as the rib angle. This rib angle is level with the transverse process of the same segmental level that the rib attaches to. Although in the mid-thoracic spine, the spinous process may be level with the transverse process of the level below, this does not necessarily hold true in the lower thoracic spine or the upper thoracic spine. These areas may have similar anatomy to the areas adjacent. For example, the lower thoracic spine, the anatomy of the vertebra may be more similar to the anatomy of a lumbar vertebra. And similarly, in the upper thoracic spine, the anatomy of the vertebra may be more similar to the cervical vertebra anatomy. And you will get large variations across individuals also.
We're now moving on to assessment of movement in the cervical and thoracic spines, and we're going to demonstrate both together, starting with cervical spine. To assess movement, I have placed Dave at the edge of the plinth here so that it'll be easier for me to be able to apply overpressure. In assessment of movement, we are looking for the usual responses that we do with any motion assessment, i.e. the quality of the movement through range, the gross range of movement available, the symptom response, again, at what points in the range that symptom response is occurring and how it is changing, and also the decision to apply overpressure or not. And this will be based on your subjective assessment. So if somebody has low irritability and severity and has no major nerve root signs or symptoms, then you can apply overpressure. If you're going to apply overpressure, you must have outruled cervical spine instability. So if there's any suggestion of cervical spine instability, do not apply overpressure or do the instability tests first, and these will be shown later on. Overpressure can be a valuable tool in motion assessment, but its decision to use it must be considered carefully. And there are a number of things you must weigh up if you decide you want to apply overpressure. Firstly, you must know the irritability and severity of the disorder, and if these are high, again, you would not apply overpressure. Also, you must be aware of any pathologies that might contraindicate the use of overpressure, and these can be found in many manual therapy textbooks. You also have got to consider what the patient's pain behaviour is whilst they are actually doing the active movement. And if the pain is reproduced during the active movement, then overpressure is not necessary. You must also be cautious with overpressure during the quadrant positions or any combined positions, because these are challenging the structures even more than ordinary movements. And remember, overpressure is a graded pressure, so the handling is crucial. And in this assessment, we are applying overpressure on a healthy asymptomatic model. But remember, every patient is different, so therefore you must watch the patient's face for their reaction, and you must question them on symptom response whilst you are doing movement and applying overpressure. You also might decide that perhaps if overpressure is not appropriate, that there are other ways of applying a little bit more load to the system. For example, you might also use an isometric pressure in a neutral position. By using an isometric contraction, you are applying a compression to the joint, and this may be less provocative than an overpressure at the end of range.
The PIVMs can be used to assess range of movement at each segmental level, comparing the movement at one segmental level with the movement at the level above and level below, but holding in mind that it is normal for you to have variations in the amount of movement that you've got at different regions of the spine and across in different individuals. As with the cervical spine, we